It's an absolute joy and honor to be here with all of you today and share the stage with my esteemed panelists who have done so much on the federal policy level and to improve the lives of patients. I'm Grace Cordovano. I'm a board-certified patient advocate specializing in the oncology space. My day-to-day is working with patients and their loved ones from point of diagnosis through survivorship or end-of-life care planning. My sole purpose is to reduce suffering, to connect people to the information, tools, and technology they need to make an informed decision about their care. Most often it's in a cancer situation, but more often than not, it's an emergency and something catastrophic where we need to move very quickly. In my role at DIME, I have the privilege of working with an amazing team under Jen's leadership who has believed in the inclusion of the patient and care partner voice from the beginning. I have the privilege of ensuring that the patient and care partner and family and caregiver voice is intimately woven across all of our projects within our portfolio. I also have the privilege of doing some policy work. I've learned and listened and learned how to do public comments through the help of Steve, who has given me full permission to not call him Mr. Posnack. I have the opportunity to serve on the National Academy of Medicine's AI Code of Conduct project, as well as being a co-author of the Light Collective's AI Rights for Patients. In order for me to do my job properly to best serve patients, I have to work with every stakeholder, and most importantly, our colleagues at the federal level. I'm going to ask you both to please introduce yourself. I'll start with you, Dr. Clancy.
Great. Well, good morning. Jen, thank you for sharing your experience. That was a gift, and congratulations on having a patient in residence. I think this has to be a first, so I'm thrilled by that. I used to imagine that patients would be teaching students and residents about getting it right, but this takes it to a whole new level. So really, really appreciate that. And frankly, I think the country's in a different place now. About 20 years ago, a former congressional leader was on our advisory council when I was running the Agency for Healthcare Research and Quality, and he had a bold suggestion: we should become the repository for personal health records for the nation. Now, on one level, it was rational, right? I mean, we didn't have any financial interest in healthcare. We were a research agency. We were independent and so on and so forth. On another level, it was like, oh my God, I don't even know if this is possible or how this would work. But what my colleagues learned was that most people didn't know very much at all. They didn't ask enough questions, and I think we are now in a much, much different place, and a lot of that is attributable to DIME and the work that you've been doing. So I'm an Assistant Undersecretary for Health at VA, a title that has deep, deep meaning in our building, but essentially I function more or less as the dean for the health system, because I've got all of the research that VA supports, all of the incredible work we do with academic affiliations. So we train residents, nurses, pharmacists, occupational therapy, physical therapy, you name it, we're training them, including we are the nation's largest trainer of chaplains, just for the record. And a lot of them are thinking about how do we use AI and innovative tools to do our work. And we have a group that focuses on healthcare innovations, wild and crazy, but it's a lot of fun, and I do actually have the best job there. So thank you.
Steve.
All right. I told Grace not to call me Mr. Posnack because that was my dad's name as a fourth grade teacher. And I'll make sure I give this side of the room. I know I'm tilted this way. You got my good side though. So my name's Steve Posnack. For those of you that don't know me, I serve as it's a long title, so bear with me for a second. Principal Deputy Assistant Secretary for Technology Policy at the Assistant Secretary for Technology Policy / Office of the National Coordinator for Health IT. And so you may know us by our 20-year-old name, as Dr. Clancy knows us, ONC. Greatest hits include the electronic health record adoption related work and standards and interoperability, and we've got a number of new things that we continue to work on, but we're going to get to talk about that.
Thank you both so much, and thanks for letting me off the hook after needing to introduce that. You did a way better job than I would have. So I was thinking about how to best kick this off. I have this amazing group of attendees in front of you, incredible and extraordinary leader, amazing panelists, and it made me think about what Jen was presenting, my role as a patient advocate. And I thought about when I was a kid, I used to love watching MacGyver. Anyone in the room watch MacGyver? Raise of hands. I would be fascinated with the ingenuity, with the problem solving, that there wasn't a single problem that he couldn't solve. There wasn't a dead end he could get out of. And it all was with his trusted Swiss Army knife, duct tape, and a few basic tools, maybe gum, maybe paper clips, a Band-Aid. And he fixed it, and I know it's TV. But as I look at my role, and many of you perhaps can relate, as a board-certified patient advocate, as the primary caregiver and care partner to 2 disabled adults, and as a patient myself, I very frequently lean into my inner MacGyver, trying to quickly understand the problem, look for the opportunities, with limited resources, connect individuals. Sometimes it's me, sometimes it's my family, sometimes it's a patient in the emergency room, someone that is an immigrant that doesn't speak English. I have to connect them to the information, tools, and technology they need as quickly as possible to make an informed decision about their care in a particular care setting and within a particular policy framework. I'm sure many of you lean into inner MacGyver moments, but many of you may be surprised that even our federal colleagues and policymakers also have to lean into their channeling of inner MacGyver moments. Dr. Clancy, I'd love for you to share a story of a time when you had to be creatively resourceful, perhaps, in your role to MacGyver a solution to help connect patients and veterans to the care they need.
So I think some of the best examples come out of the pandemic. Now, VA had a huge advantage because we've been doing telehealth in some fashion as almost a little boutique adjunct to the main show since about 2006. It was not integrated seamlessly with the rest of clinical care and so forth. But when the pandemic came, we had a much stronger foundation. So we already had a tele-ICU program, which was quite amazing. We had just started to launch tele-oncology. In fact, we were applying for a grant application about 2 weeks before lockdown, and that was amazing. But what really amazed me during the pandemic, and I'm bragging on my colleagues now, was how much people leaned forward with tele-rehabilitation. Now, I learned about a whole lot of this almost by accident, but my favorite example was, whole health at VA, by which we are focusing on veterans' mission, their goals, not just at the end of life, but, throughout their life. And this notion of a new mission when you leave active duty turns out to be very, very important. And there's been a substantial embrace of complementary and integrative technologies. So we have in our system a woman who is both a physician and a licensed acupuncturist. Now, you couldn't come in for acupuncture during COVID, so she was teaching them about AccuTouch, which many veterans reported very positive experiences with. This idea of just being undaunted by the current reality, I thought was amazing. And we were doing so much in this space that I'm sad to report that we weren't cataloging it as effectively as we could. But you name the kind of rehabilitation, whether this is post-op for hip or knee replacements or geriatric rehabilitation, we had figured out how to make that virtual pretty rapidly.
I was really floored with that story when you had mentioned it, and I was hoping you would be comfortable sharing that. I thought that was really an amazing example of here's a federal colleague, and they walk the line of following policy and all these rules, and here we're being innovative and creative. Thank you for sharing that with us. Steve, can you share any kind of a MacGyver moment in your policy world?
Sure. There are a few that come to mind, but I guess, the other thing I would kind of convey to folks as well is it's not just a quick thing sometimes, right? Even the pandemic experience took some time. And so I would look across, since we're looking at 2030, but also perhaps like the last 10 years worth of our work in the standards and interoperability space. So we started in 2015 with a regulatory theory that if we push the industry to have a application programming interface, I'll use the acronyms first, to enable patient access, that there would be some response. And we didn't adopt the standards because they weren't there yet, but we set the kind of functional requirements. And then we started to track things over time, and lo and behold, the standards matured, the regulatory kind of structures fell into place, and as part of our 21st Century Cures Act rulemaking, we had standards-based APIs for the first time, the FHIR standard. Fast forward again now, we're looking at how to best leverage that for network-based, exchange, for what's called bulk FHIR, so population-level data exchange. So you start to see these things build over time. And I guess I don't want to say that's adding more duct tape, because that may be the wrong metaphor. But we found a way to work with what we had and then continue to expand it in an incremental way.
I love that. Thank you so much for both of your perspectives.
I had one more just to
Oh,
share.
please, please.
MacGyver moments are not all about technology, right? And so we regularly mine and survey our colleagues in the field because they're doing the work of seeing patients. So one of the best ideas that ever surfaced that every system could do today was to include a Narcan kit in the defibrillator box. Think about this. The defibrillators are there for a reason. They're in every single federal building and so forth. And last night, the chief nursing officer assured me that she had double-checked all the boxes in our building here in DC, buildings. They've all got it. Why should someone have to go run after a Narcan kit when you could actually have it there? So I emphasize that because a lot of the MacGyver moments are going to come from the people who had to run up 2 stories to find a Narcan kit or whatever the issue is at hand.
Sounds like bundling. Bundling came into my mind
yes.
as we're thinking about problem solving and opportunities. Thank you for sharing that. Our healthcare system is at a breaking point, but there's immense potential. Patients' lives are at stake, and I see it every day. And Jen, thank you so much for sharing your story and what you have gone through. Now is the time to be bold. Now is the time to be creative. Now is the time to look for problems, find the opportunities, take the tools we already have, and find ways to harness the power of digital health transformation to improve the lives of patients, but also to elevate and improve our healthcare ecosystem as a whole. Now is the time to leverage our current policy landscape and to really use it as a catalyst, especially as we face the unique headwinds and tailwinds that healthcare here in the US has to offer, so that patients can get the care they need no matter where they are. I'm going to ask all of you, I'm going to run with this theme of MacGyver since so many of you raised your hand. You're not off the hook because you're not on the stage. I'm going to ask you to channel that inner MacGyver, and later this afternoon we are going to ask you to bring that MacGyver problem identification, opportunities, and strategizing and creativity to our co-design labs. But for now, I'm going to kick off our first question, and I'm going to look to you, Dr. Clancy. The VA became a proving ground for telehealth and creative solutions during the pandemic. Looking ahead, what's one practice you've proven that you feel strongly should be scaled across America right now?
Well, I don't think we've left any stone unturned, as I described with telerehabilitation, in terms of how far we can take this. I mean, we've been using telehealth for both synchronous interactions as well as asynchronous interactions, which means that I think we have exceeded every system in the United States. There's Eric Schneider, who was at NCQA previously, in terms of the percentage of diabetics who get retinal exams, right? Because we take the picture and forward it to ophthalmologists because we had the technology to do that. I think that we've got to get to a place, and we are getting there step by step, where this is part of the main show. I mean, we see patients 3 ways. We see them in our system, we make an appointment, depending on where the veteran lives and whether we have the capacity to deal with the issue that they have. We may be referring them to partners in the private sector, or we can do it virtually. We have historically been running these as 3 very separate approaches, but are coming much, much closer to this is all about the patient, which is what it needs to be for sure.
Thank you. Steve, I'm going to ask you a little bit of a different question. Recently, the information blocking enforcement announcement now has everyone's attention. What do you anticipate is the greatest changes that we can expect in the next 12 to 24 months?
Sure, without giving away any state secrets, right? So Other thing that our office is responsible for includes the information blocking regulations, if you've heard of them, hopefully. We had a boot camp recently to engage the startup and I would say like early innovator community, and we're looking to do that again for everyone's benefit. So keep your eyes peeled for those types of opportunities in the future, trying to double down on our engagement and education that we can do in the field. Again, to your earlier points, we have now, since the 2016 Cures Act, adopted regulations on our side. Our colleagues at the Office of Inspector General have also adopted their regulations. Our colleagues at CMS, among other parties in the department, have established what are called disincentives for healthcare providers. So I talk with my hands, I gotta make sure the mic stays in one place. All of the kind of triangulation that needs to occur for these rules to be put into effect is there. And we make the opportunities that we have with every administration. The leaders that we have are very focused on enabling the private sector, and one of those steps is to make sure that these rules are enforced. And so you have a renewed, I would say reinvigorated Office of Inspector General that's been charged to take on more work. My office as well, through our certification program, looking at instances that we have separately for our certification program and information blocking. So I think you'll see probably 2 or 3 things. One, more frequently asked questions from us that we will be able to provide from an educational perspective. The second will be action at some point from our colleagues at OIG. They do their own thing. They're independent. Don't forget, they're an OIG. And then work on our side from a certification program perspective as well.
I really appreciate, and many patient communities and other stakeholders appreciate, there's been a really big push, I think, in the last year or 2 on education coming out of ONC and ASTP. A lot of great blogs, webinars. Your team is extremely responsive to questions. Me personally, I'm a big question asker. And I think even guiding people through new proposed rulemaking and just this opportunity and push for education. Dr. Clancy, what are your thoughts on the impact of and importance of education with respect to physicians in this whole concept of healthcare transformation?
So many physicians are very excited about healthcare transformation. It's not like you're starting from ground zero. In fact, many are unique problem solvers, and if they see a problem, they're just going to blaze forward. They're less inclined or have less training in thinking about how could we scale this, right? They're trying to fix the problem in front of them. So that's where we're trying to provide support. Actually identifying what are those ideas that they have. Show me how it's worked. Would you be willing to share this with colleagues? And we're going to try to evaluate to see, is this scalable, and so forth. So many different ideas. Just by way of one example, for the past 7 or 8 years, we've had a program we refer to as precision oncology. So the innovative thing here is bringing research and delivery of clinical care side by side. It includes tele-oncology. It includes a lot of decentralizing clinical trials. So no, you actually don't have to drive 3 hours to have a blood test when you can get one closer to home, and so on and so forth. And we're also doing that with treatments as well. Yes, for the main initial diagnosis, that's more likely to be happening at one of our facilities. But if you live a distance away and don't have a designated driver and all that kind of stuff, it is ludicrous for you to have to do that drive every day to get radiation oncology or whatever else you need. So I think that's been very exciting. Again, I think many doctors are doing that. Some doctors have left because they've come up with a really breakthrough innovation and started their own companies, and we don't make it that easy for them to continue to stay and work for us. Now, what happens oftentimes is that they have this company and they're doing astonishingly well, and they give us back 1 or 2 sessions a week working without compensation, which is lovely, but I think that we could actually, frankly, do better than that.
Thank you both. Steve, this one's going to be for you. So interoperability has been long an aspirational goal, and you have been a tireless evangelist over your years of service. The current administration, from what I understand, is clearly sending signals that data liquidity, digital identity, computable consent are on the horizon. If data is today's currency, Do you have some thoughts on what the biggest untapped opportunities we may be missing in health information exchange?
That's a big question to unpack. So part of the motivation for our office, what gets me out of bed, is that there are better ways to do what we're doing right now. And it is a little bit of a combination. I know we use MacGyver, I'm gonna use another. Since we tested the crowd's pop culture references, Knight Rider. And
Let's go.
You remember the car, right, Kit? And so, as we look at some of the potential for all of the new tools that are available to help synthesize the data that we have, engaging individuals in their care, I think we're seeing at scale, as Dr. Clancy mentioned, the scale of access to, the GPTs of the world. Dr. Google has been replaced by Dr. GPT and Dr. Gemini and Dr. Claude and all the other LLMs that you want to talk through. And it's really kind of I don't want to state a number and then not be able to reach my number, which is the speaker's dilemma. So first it's about getting us as individuals access to our information and our entire record when we're able to do that. And that's scattered still. And so we have a lot of work still to do in that space. The second is to help our overworked clinicians across the entire spectrum of that profession, nurses, docs, et cetera, to have better tools that can help synthesize all of the data that we're shooting kind of at them in different ways. We've been really successful in improving connectivity and moving data, but being able to synthesize all of that information for them in ways that achieve the clinical workflow that they're trying to work out, figuring out what data is specific to the type of care that they're delivering. All those things are factors where we can do a much better job at.
Thank you. Dr. Clancy, I'd like to shift to the VA, where the VA has been doing some of this already and sort of in the proving ground for innovation. Could you talk to us about how you're integrating digital tools like remote monitoring, AI scribes, simulation training into everyday care, and what lessons should commercial innovators take away from that?
What a great question. So next month we are launching ambient dictation. We had preceded this launch with what we call a tech sprint. For those of you not familiar with that phrase, I hadn't heard about it either, but essentially we put a call out to industry and said, come show us your product. And you're gonna have to show us in our simulation center. We have a national one in Orlando, and if you're ever in Orlando, just let me know. They'd be happy to give you a tour. It's pretty amazing. And we picked the winners, and then they had another few gates to go through. And so we're really excited about this. Obviously, there's been a lot of sensitive policy issues in terms of informed consent and so on and so forth, and protecting veterans' privacy, but people are very excited about that. In fact, we had a couple of the leaders of the two companies will be starting with a bridge and no-tex next month in last week. And we were challenging them on a number of fronts, and it was quite fascinating to hear what they thought about. So one of my friends wrote a commentary in the New England Journal about the fact that these programs don't necessarily include socioeconomic information. Now, this is someone who spent most of his career taking care of patients in a public hospital setting. And he thought maybe this was a bug in the system, and then was informed that no, this was a feature, not a bug. And I immediately sent him a little fan email because I vividly remember writing down in charts information like has been feeling stressed because her grandson was at school and one of his classmates died from a stray bullet or something along those lines, right? And when you remember that, because you actually have the information in front of you, people think that you're a genius or something. And that's very much impacting health. So I think this is going to be absolutely fascinating. The one thing I would say, just to add to Steve's wonderful comments about health information exchange, is we've got to get the business processes right. And long ago at ARC, we funded some of these startup exchanges, including one in the state of Delaware, which is so indispensable to us now. I don't have adequate language to convey, because many veterans get some care from us and some in the private sector, and you can retrieve it. But if you're not building it in, just like you get vital signs when you are brought to an emergency room, you're going to miss lots and lots of opportunities. And that's not a technical problem. That's a problem of just making sure that we've got business processes to go with it.
Thank you. I'm going to turn to coordination across agencies, something that you do every day and you do in a different way, but both a lot of quarterbacking, coordinating, and herding sheep, I imagine, and troubleshooting. So patients and providers often experience fragmentation, multiple systems, multiple portals, multiple locations, multiple rules, frameworks, different payer coordinations. How are your agencies working with others to align on interoperability, digital health adoption, and AI governance? First one to bite can go.
I can go first, since we have two different departments here too. So I'll do the HHS representation. Coordination is obviously in our middle name. And one of the areas that we, is closest to our wheelhouse of work includes our United States Core Data for Interoperability. And so USCDI is the acronym. Over the past several years, we have created what are called USCDI Plus initiatives. So understanding we have a core set of data, I like to call it the USCDI Prime, that we manage and maintain. And then we work with other partners in HHS in particular to better understand their data needs that could be added to our core data set. So we have work with NCI for USCDI Plus Cancer, our colleagues at HRSA for their UDS modernization. There are a few other agencies that we work with, CMS in particular on quality and CDC on public health. So a number of different areas where we can say, how can we as a community drive consistency across our federal partners so that for you all that are interacting with us, you've got one set of responsibilities. If you collect that data once, you can reuse it with multiple agencies. And so driving that consistency is one of the things that we do from a coordination perspective.
Yeah, so I have lots of examples, but probably the most timely one is that we've been engaged with CMS for several months now because the Elizabeth Dole Act, which passed. Now, Elizabeth Dole, the former senator and former transportation secretary, quite a leader. Obviously, her husband was a remarkable hero from World War II. So it seemed quite fitting that the Congress would write this bill in her honor. It has multiple components, but one of those is to have a strategy for VA, for value-based care. Now, when you think about value-based care, we're often thinking about, well, we pay multiple little services and how do we bring them together, like payment bundling or things like that, which is all fine, and bigger initiatives like accountable care organizations. We're almost an accountable care organization to start. But what we are trying to figure out is how do we get really robust about health outcomes and also prevention opportunities in a broader way than simply checking the boxes on evidence-based recommendations. Nothing wrong with that, don't get me wrong, but actually looking ahead in terms of how people can live healthier lives. That's why our whole health program is so important. But again, figuring out how do we make that consistent and so that we can and do routinely scale that across the enterprise, I think is important. One modest example is our new team was very interested in after-hours care for veterans. Anyone here who has not had a problem trying to reach someone after 8 to 4 sessions? Okay, I don't see any hands up. Either that or people who have suddenly become paralyzed, but I'm going to assume that like everyone I know and I'm related to, this is an issue. Well, it turns out that across our system, we're doing an amazing amount of after-hours care. We're not doing it consistently yet. And I think that there are far greater efficiencies to be gained when we do that. CMS policy-wise has been hugely important, and I'm really seeing big, exciting changes coming at the Centers for Medicare and Medicaid Innovation. Just focusing on outcomes and prevention in very different ways, which I think is exciting. But we've actually got the testing grounds to see, does this work and how does it work and so forth.
I'm going to come back to you and kind of build on your response, if that's okay.
Yes.
Can we talk about connectivity and access now to veterans that are in rural and underserved areas?
Absolutely, and that's something
And Steve, you're next.
that has been something top of mind. Depending on which source I'm looking at, either a quarter or a third of our veterans live in rural areas. I'm not talking like lovely exurbs, I mean seriously rural. And unlike most systems, we don't have the luxury. We have to provide care to all veterans, right? So we can't say that's not a good market to be in. We're in it because veterans are in it in some fashion. We have leveraged multiple opportunities like Lifeline to get veterans discounts on broadband access for a while, and I think we still have something called the Atlas program where industry actually donated access and a place to get it. Those of you who've seen a Mamava at the airports, I'm talking about a setup like that. In fact, astonishingly enough, one company actually managed to bring these down to Capitol Hill for a little show and tell, which I totally, totally loved. When you're looking at a state like Montana, which is huge, right? We have a fair number of veterans who live up by the Canadian border. I think that's at least a 3-hour trip, even with very high speed limits, to get to our main facility. So if they could go to, say, a VFW hall where they've put one of these in and get privacy and access, that's a big deal. The one thing I don't want to omit is just, even when broadband is available, there's also the issue of access vis-a-vis how hard is it to use the equipment. I mean, half of our people are over 65. I'm the last person on planet Earth to be ageist in saying this, but I will say that what seems extremely easy for someone who's 30 often is not for people who are older and may have one or more sensory impairments. So we've tried just about every collaboration you can imagine, including one of my favorites is a collaboration with the local volunteer fire department to help veterans who live alone actually understand how to take advantage of virtual care options. I mean, this is a win-win on both sides, right? Because this is someone that a fire department won't get a call that he's on the floor and he might have been there for like a few days because they were actually able to access their care. I think on the clinician side, we're going to need to make it a bit easier for some of our clinicians as well.
Thank you. Powerful. Steve, I want to ask you now, as we have data liquidity, we're talking about broadband access, AI-enabled decision-making and support. We have this national infrastructure that we're aspiring towards. What policies from your perspective are going to make a difference, or maybe that we need to address some of the gaps in care in more underserved and rural areas?
Yeah. So first thing is public service announcement. There is a $50 billion with a B program that CMS released for rural health transformation. That's directed to states, but I would encourage you all to check that out, especially if you support individuals in states. That will be a big opportunity for those of you that remember the estimates from the electronic health record adoption program. This kind of parallels that, or is in fact could be more that will go out to the states in terms of supporting rural health transformation. The other thing is Dr. Clancy mentioned, we are in healthcare and it is a financial enterprise as well. And so I think, as we start to look at how payment is orchestrated and the shifts from fee for service to other alternative payment models, that has a huge impact on whether or not, certain interoperability investments seem like they have an ROI. And so, we're working on helping to build out additional national infrastructure that would be through the Trusted Exchange Framework Common Agreement. That is a public-private effort that we help to lead from the 21st Century Cures Act to enable nationwide connectivity, a single set of participation requirements, but it's largely driven and a lot of participation from our private sector partners.
Thank you, very exciting. And I'm going to plug a good colleague and friend, Lisa Barry, just came out with a really great post on how to navigate that and all the things that you need to know, which was super helpful to me and patient communities trying to understand the crux of it. So between the two of you, speak to them both. I'm going to talk now, try to close us out with signals to industry. And this is going to go to both of you from your perspectives. What signals should innovators, payers, providers be listening for in the next 3 to 5 years to stay aligned with policy directions?
So I think the most important thing that industry can get right is to make sure that it works for the target audience. This is not about, wow, we want another like big AI initiative because it sounds really cool. We've got to have faith and absolute rock solid confidence that this is going to make care more effective for veterans and frankly give them more of a voice in their care. And you can't do that sitting in the industry lab. You just can't. So we welcome your coming to us with ideas. We have a lot of cooperative research and development agreements going on and so forth. Because no technology works out of the box. I think that used to be almost a banner at the Office of the National Coordinator for a while. And it's wildly important to make sure that this is working for the people who are actually providing care and receiving it.
So critically important because we don't see enough patient voices, care partner voices, family voices, provider voices, doctors, nurses. So definitely need that hands-on insight, expertise, guidance, not just at the end at deployment at adoption, but continuously longitudinally throughout, which means you need a budget for it up front. So just a plug there. Steve?
Maybe to change the kind of cliched statement, we're at the government, tell us how we can help. Because, especially, with the administration thus far, we are very much interested, like we touched on, in information blocking. The way that we approach that is through complaints. That's the process that the Congress has stood up. So if we don't hear from you all, then we can't take action. And so please, submit those complaints and submit that feedback, ask for questions and clarifications. The other areas that we could definitely use your help on is to highlight where there's friction. We are in a deregulatory environment. For those of you that track the spring regulatory agenda, which kind of came out in like the late summer this time around, there are a number of regulatory actions that I would encourage you to check out. Our office has a deregulatory action on the docket as well. And so as there are friction points, you definitely see an appetite across the policymaking aspect of the administration to address those. And I want to thank you all for responding to many requests for information. I know there wasn't just one from HHS, but from OMB and a variety of other sources. Every one of those gets funneled in. We've seen all the submissions that you all have put in across the different executive branch requests for information. And so I would say keep that coming, but don't see that as your only opportunity to provide feedback. And so if you have specificity, which is important, and a particular challenge that you can point to the provision of the CFR that's causing some friction, that's going to be really helpful for us from a policymaking perspective.
Yeah, so just to summarize that, I would definitely be paying a lot of attention to RFIs because they are a very important signal of where we think the next opportunities are, where information is going to be pretty mandatory. And a plug for DIME, I just don't know that many groups now that are really bringing patients into this in a way that is, in my view, imperative. So thank you, but it's also something it's very easy to overlook, and we're not going to get to where we need to be without it.
I want to ask everyone to now give my co-panelists a round of applause, please. Thank you both. And before we leave the stage, I'm going to say that if MacGyver taught us anything, it's that the tools to solve the problems we need are in front of us, in our possession. We need to be bold enough to use them creatively. We need to identify the problems. We need to identify the opportunities and be bold enough to collaborate and use them differently. I'll ask you to channel that into this afternoon's co-design labs. Make sure you sign up for one of them. And on that, thank you very much. Enjoy the rest of the event.